Hello, everyone. I'm Gabby Villalobos. I am from VCU. Thank you for allowing us to come and join you all. I'm here with Dr. Alex Krist, and we're going to be talking about the Virginia Cancer Screening Research Network and one of our new trials, the Vanguard study. So, Alex, do you want to start us off?
Sure, yes. So, yeah, nice to see everyone. So, just so you know who I am, I'm a family physician and I teach and practice up at the Fairfax Family Practice Residency. I also help to do research through Virginia Commonwealth University with Gabby and others, and we run our state's primary care practice-based research network. So we work with about 526 practices throughout all of Virginia to do research that matters to primary care practices. And cancer screening is one of those topics that fit into that. So that's a little bit of who I am. And Gabby can say more about herself when she comes to her section. And the way we're going to do this is Gabby and I are going to talk about this cancer screening research network and the study that's going on, but we're going to talk about cancer screening in general and sort of why it's important and what's sort of recommended for cancer screening. And then there'll be some time for questions and discussion. And the questions and discussion can be about this study, and it can be about cancer and cancer screening. Anything that is important that you'd like to talk about, we can cover here today. Next slide. So this is something that's going on across the whole country right now. The National Cancer Institute created this network called the National Cancer Screening Research Network. And the purpose of this network that the National Cancer Institute created was to try and study the future of screening for cancers. And with a particular focus on new technologies that are emerging to be able to understand cancer, to find it early and to try and help reduce deaths from cancer. And what you're seeing on this slide is that this is a big national effort. So we have the National Cancer Institute involved, and they have a coordinating center through this Fred Hutchinson Cancer Center and these different steering committees, and then they have what are called access hubs. So Virginia is one of 10 different access hubs across the country that was invited to be able to participate in these different studies. And you can see the other hubs are like Kaiser out on the West Coast and Oregon Health Sciences Center, Colorado. We've got the Department of Defense, the Veterans Administration, Oklahoma's involved in their Indian Health Services. So there's this big national effort of people coming together to do these studies to understand new technologies and different ways to find cancer early and prevent deaths from cancers. Next slide. So our Virginia hub is a collection of a bunch of different groups. So it involves our primary care practice-based research network. So really all primary care practices can be involved in some way. It involves 3 health systems. So the VCU health system, Centera and Inova came together to participate in this, and EVMS as well. So 4 health systems, universities. It involves the cancer centers at each of these places. And it also involves our Translational Science Center, the Wright Center, and that's partly where this group is involved in some ways. But what we tried to do was to really bring most all of Virginia together to be able to participate in these studies if they're interested. And for the future, we might be engaging other health systems and look at other regions as well for participating more. Next slide. So the first trial that the different hubs, access hubs, were asked to field as part of this cancer screening research network is this trial called the Vanguard trial. And if you're interested in it and you Google it, there's actually been a lot of interest in a lot of attention in the Vanguard trial. So the Vanguard trial is meant to answer the question about whether the new multi-cancer blood detection tests work better than usual cancer screening. So there's going to be two phases to this. We're in a pilot phase, which is kind of looking at the feasibility and design of this. And Gabby and I will talk to you about this, the pilot phase design, because that's what we're doing right now. It's really looking at this goal of how do we design the big definitive trial to answer whether these work. But the pilot is like a mini version of the big definitive trial. So collectively, all the access hubs are being asked to recruit 24,000 people and randomize them to get one multi-cancer blood detection test versus another multi-cancer blood detection test versus continuing with usual cancer screening. We'll talk a little bit more about that in a little bit, but the idea is to kind of see, is it really feasible to do this? So definitively answering the question of, do these new tests prevent deaths from cancer better than usual cancer screening, is probably going to take something like 150 to 200,000 people to do that trial. And after we do this Vanguard trial, to understand sort of what's involved with doing all this, which will be following these people who get randomized to this for 3 years, then they'll be launching this larger trial. So this is kind of a really neat effort that the National Cancer Institute is doing to make sure that the study is really designed right and well and is going to answer what we want before we start going and working with 150,000 or more people. But it is doing essentially a mini version of this study, which we'll talk about, as I said, a little bit more. Next slide, Gabby. So you're probably thinking, well, what is a multi-cancer blood detection test? So you may be familiar, I hope, with usual cancer screening. This is things like a colonoscopy to look for colon cancer, or a mammogram to look for breast cancer. But the multi-cancer blood detection test it's a new test that basically takes one blood sample from a person, and it can test if they might have a dozen different cancers. So it doesn't just check for one cancer, it checks for a dozen or so different cancers. Now, it doesn't tell you definitively, do you have cancer or not? That's not how it works. It's looking for cancer signals. So it's looking for some things that could show up in DNA or RNA or proteins floating around in your blood that might suggest that you have cancer somewhere else. Now, it could actually be in the blood, but it could be your lung, colon, pancreas, breast, other places like that. And, you know, the promise of the new multi-cancer blood detection tests is that they might help to find cancers even earlier, before cancer symptoms appear. They may work better than usual cancer screening. Right now, they're meant to be used with usual cancer screening. So we're not testing like, do you get this or the usual cancer screening? The Vanguard study is going to test, do people get this in addition to usual cancer screening? So that's what their approval is, and what they're looking at right now with this. Now, they're not all fully FDA approved, although there are a number that are getting FDA approval. And there are a number of trials going on right now that are testing these tests. And we have pretty good data for the multi-cancer blood detection tests about what's called their sensitivity and specificity. So what that means is there's pretty good data that shows that these blood tests can actually find cancer. So we know that. And we also know something else. They also have what's called a false positive. So a person can have one of these blood tests that suggests you might have cancer in the colon, but then when we go and look at your colon, there is no cancer there. So that's called a false positive. So we actually know the data on how well they can detect cancers. We know the data some on whether on the false positive rate. What we're lacking is data showing that doing this in addition to usual cancer screening saves lives. And that's the ultimate goal of what we're trying to do with these different studies. And the Vanguard study will be the first step at answering that. Next slide, Gabby. So I'm going to talk for a second about what's usual cancer screening. And this is what we want everyone to go and do right now anyway. And the patients who are in our trial, we're going to be encouraging them to go get their usual cancer screening, no matter what arm of the study that they're randomized to. Here on the left-hand side of your screen, you'll see that the different tests that are currently recommended for people to get. So the first one is colon cancer. There are two ways you can check for colon cancer. There's directly looking, so that's like your colonoscopy or a sigmoidoscopy, and then there's stool tests. The colonoscopy, all of these things are recommended to start at the age of 45 and to do until the age of 75. Colonoscopy tends to be the main way of looking. Most doctors don't do sigmoidoscopies now. The colonoscopy looks at all 6 feet of your colon. You meet with a doctor called a gastroenterologist. You have to drink some liquid the night before to clean out your colon. You go to the hospital, they give you some anesthesia, and they do put a tube in your bottom and look at the whole colon and see if there's polyps or cancers. And if that test is normal, that's something that you repeat every 10 years. And you can get screened all the way up to the age of 85 for colonoscopy or for colon cancer. We decide to stop between 75 and 85, depending on a person's health and their interests. So it's an individual decision on when you stop, but it's somewhere between 75 and 85. The stool tests either look for blood in the stool or they look for blood and DNA changes in the stool. And the stool test that looks for just blood is something you do every year from 45 to 75. And the one that looks for blood and DNA you do every 3 years. And if those are positive, you need a colonoscopy. So they're basically a way of figuring out who's going to benefit most from a colonoscopy. The mammogram is the test for breast cancer, and that's recommended for women age 40 to 74 to get at least every 2 years to look for breast cancer. For cervical cancer, the test is the pap smear is what we classically think of, but it's moving more to a test called an HPV test. So HPV is the human papillomavirus. Most doctors right now, when they do a pap smear, they also do the HPV test. HPV is the virus that causes cervical cancer. But the recommendation is age 25 to 65, maybe age 21, to get the HPV test every 5 years. And that can be done with the pap test as well, or just the HPV test alone. And in the future, interestingly, we're going to see new tests where women can just do the HPV test, collect it themselves, and you won't need the pelvic exam and other things with a swab, and that will work just as well. Those are starting to emerge more here in the United States, but they've been tested and shown to be very effective in Europe and other countries. The test for prostate cancer is the PSA test. And what's recommended is that men age 55 to 69 talk with their doctor every 2 years about whether they should get a PSA test. And the reason it's talk with your doctor is because the PSA test has a lot of false positives in addition to some benefits. So the way to think about it is if 1,000 men get a PSA test, we'll prevent 1 or 2 from dying from prostate cancer and 3 from getting metastatic prostate cancer. And that's great. We really want to prevent deaths from prostate cancer. The trade-off, though, is about 200 men over their lifetime will have a high PSA value, and they might need to go get biopsies. And about 100 men will be diagnosed with prostate cancer, and about half of those will be overdiagnosed, meaning men wouldn't know they had it except for getting the blood test. So what that means is that men who are more concerned or at higher risk for prostate cancer, well, they might want to get the PSA test every 2 years. And men who are a little more worried about the healthcare system hurting them and false positives and are lower risk, they may not want to get the PSA. But that's something we want people to talk with their doctor about. And then for lung cancer, what's recommended is that men and women age 50 to 80 who have at least a 20-pack year history of smoking, so that's an average of smoking 1 pack per day for 20 years, get a low-dose CT scan every year. And if you're a past smoker, you would get it as well if you have a 20-pack year history of smoking. But if you're 15 years out from quitting, then you may not need to get this test. So we want everyone to get all of these cancer screening tests. That's something we want them to do already. If you, for the people who enroll in the Vanguard study, which we're doing right now, they get randomized to arm 1, which is the Guardian MCD test. And you can see it tests for these cancers: breast, colon, esophageal, stomach, liver, lung, ovarian, pancreatic, bladder, and prostate with the blood test. So they would get that test when they enroll in the study, again, 1 year later, and they'd answer a questionnaire when they enroll in the study 1 year from now and 2 years from now. And then the second arm of the study, if patients are randomized to that, they'd get the ClearNote test. And the ClearNote test looks for all except for bladder and prostate cancer. And they would do the same things about the blood test when they enroll in a year later and complete these surveys. And then the third arm is our control group. And they don't get the MCD blood tests. They do have their blood drawn because they're actually you're not randomized until after the blood is drawn and sent off to the lab. But they don't end up having their blood tested with these tests. And one thing that's really important to know is in a trial like this, we really need these control group folks. And there's two reasons. Like, one reason is in order to answer this question, we have to have a comparison. So we need to be able to look at, well, how do arm 1 and 2 do compared to arm 3? So that's an important thing. But I'll even say from a person perspective enrolling in a trial, we don't actually know if these tests are going to save more lives or they're going to have more false positives and maybe cause more harms. And in a research study like this, sometimes the control group actually does better than the intervention group. So sometimes people are disappointed when they find out they're enrolled in the control group. But I like to encourage them not to be. There is a chance they might actually do better than the other groups, and all of the groups are contributing to our understanding of, does this help or not help? The last thing I'm going to say, and then I'm going to turn it over to Gabby, who's going to talk a little bit more about the study and what we're trying to do, and she'll ask you all some questions as well, is what you'll see is that these blood tests actually look for cancers that we don't have routine cancer screening for. So we don't have tests for lung cancer and esophageal and stomach cancer or pancreatic or ovarian cancer or bladder cancer. There are some tests, but they've not been shown to work, or they actually might be shown in some cases to cause harm. So you can see how the blood tests might have a benefit, because in addition to finding cancers earlier than through these other cancer screenings, they might also find cancers we don't now have tests for. But that's all what we're trying to answer and to learn in this research study that's going on across the country. Gabby?
Next slide, please. So to explain a little bit about what participating in the trial is like, we meet with the potential participant to review study details, make sure eligibility is met. And the eligibility includes, the ages 45 to 75, and no history of cancer within the past 5 years or cancer treatment within the past 5 years. And of course, willing to provide a blood sample. And we do say 1 blood sample, but it is 4 tubes of blood. I like to make that clear to everybody that is what is needed. We complete a brief questionnaire, which takes 10-15 minutes. And the questions pertain to what cancer screenings have you completed, and what does your family history of cancer look like? There's just a few questions about anxiety, about getting diagnosed with cancer as well. And then we do the blood draw. And for participants get $25 gift card. Then we enter the participants into a system. It's a lot of details we have to do. And once we enter it, input information, including demographic information and ensuring we've met all our process, we then get told which group the participant was randomized to. So it's something that we can't select which group. It'll just tell us, which labs to send the blood samples to. And then we are in the Virginia Hub, we made the choice to be able to communicate that to the participants. So some of the other hubs are blinded, meaning that they do not communicate that to their participants. We do communicate that. So we typically, by the next day, check back and tell people which group they were randomized to. So as Alex mentioned, it's either going to be the arm 1, arm 2, or the control standard of care group. Then we receive results within about 4 weeks. Once we ship them off to the lab, if they are going to be tested, we get the results directly to us. They don't go into a health system record. They get delivered to us directly, and then we communicate them to the participant as soon as possible. There's a potential that we will get abnormal results. And if we do get abnormal results, what we do is we also set up a time for the participant to speak with our study doctors, like Alex, to go over and review what the recommended next steps are. We complete diagnostic workup, and that is done within our health system, so either VCU, Inova, Centera, and we help the participant set up the appointments, help with the navigation, and then we communicate, what are the findings or what are the additional diagnostic workups needed. And it's important to note that the study pays for that diagnostic workup. So that's not something that the participant has to pay out of pocket for. Next slide, please. So we are engaging Virginia residents. We want to make sure we have a good selection of people from across the state, be able to enroll anybody who's interested in enrolling. We plan to enroll 2,000 individuals. We started in June, and we have until June of 2026 to enroll. And we've had a lot of interest. And Alex and a couple other of the investigators did some brief media interviews, and word definitely got out there, and we've gotten a lot of interest. But we want to make sure we are able to include, as I said, residents across the state. So who's eligible to enroll? As I mentioned, 45 to 75-year-olds, no cancer diagnosis in the past 5 years, willing to provide a blood sample, and willing to complete the same process a year from now, and not enrolled in a similar trial, though we don't think there's a similar trial currently going on. Next slide, please. 2026 to enroll, and we've had a lot of interest. And Alex and a couple other of the investigators did some brief media interviews, and word definitely got out there, and we've gotten a lot of interest. But we want to make sure we are able to include, as I said, residents across the state. So who's eligible to enroll? As I mentioned, 45 to 75-year-olds, no cancer diagnosis in the past 5 years, willing to provide a blood sample, and willing to complete the same process a year from now, and not enrolled in a similar trial, though we don't think there's a similar trial currently going on. Next slide, please. So it's very important, as we've said, to include rural community members. And so we want to get some of your feedback to find out what is the best approach to recruiting and sharing this information with residents who live in rural areas. So who are your trusted community champions? What are the best locations for us to set up for community events? One of the most important things that I try to focus on is make this as convenient as possible to the participants. So we'll go out to you. That way no need to come to Richmond. We will travel to you. We can set up weekends, daytime, evening, whatever is most convenient, and have different options. That way, anybody that's interested, we can make it accessible. Currently, we're also providing compensation with Walmart gift cards. So something I want to take into consideration is that something that would work well for rural community members, or is there a better option? And what concerns may there be about participating in a study like this? So I don't know if this, you want to chime in, Alex?
Well, yeah, Gabby, I wanted to just kind of highlight with the slide some of why we're talking about this and talking with you all is one of the interests with this study is to make sure that we include people who may not usually be represented in trials like this. So, there are a number of trials that go on across the country looking at new types of medicine and things like that, and they're often like more urban centers which are closer to universities and people who go to these university settings are more likely to be in these types of trials. So there's a real effort to include a more representative collection of people for these trials. And rural communities are often overlooked in trials. The other thing that I'll add is that rural communities have higher rates of cancers. People who live in a rural community have a higher rate of cancer than people who live in a suburban community. So it's also a potential greater benefit. So that's one of the reasons we're looking to think about how to be really inclusive in how we go about this.
So could we open it up to hear some feedback?
Yeah, and questions. There was a question I saw that was posted in there. So Zach, is it possible for discussion and feedback?
Yeah, that's perfect. That's exactly what we want to do. The question in the chat was, how do we provide the blood?
Yeah, so that's something we come to you and collect it. So I work directly with enrolling patients. So I go out to primary care practices if that's where patients are enrolled or if that's how they're referred. And if not, if we do community events, most of our team is trained phlebotomists, so they will do the blood sample. We have a Massey van that we will take out to community events, and we will do everything on the spot. We can do the whole start to finish in person, or we can break things up as well and do like the consent process, the questionnaires virtually, either on Zoom or on the phone, and then just meet you when it's convenient to collect the blood sample.
And I'll add that I think, one of the catches is, as we were saying in this Vanguard trial, we're supposed to be following people for 3 years. So we're looking to make sure that if we enroll someone that we're going to have their contact information and that, we'd be able to contact them again a year later, and a year after that. And we also want to be able to review their medical records. So if you have a regular primary care doctor or medical home or place that a person goes, we'd want to be able to take a look at their medical records just to see what type of care they get and what happens over time with people. So, if you all have thoughts or input or feedback on best ways to, engage and work with people in your community, family, friends, others who might be potentially interested and eligible in participating in an effort like this, that's what we're interested in hearing about.
So they followed up asking the sample would be collected before the incentive. So would you send a representative to come collect the sample, or would they be doing it themselves, like an at-home test?
No, yeah, we do it all. We do it, the research team members. One, we have special tubes that we're required to use. So we can't just, you can't go to your doctor and have them draw your blood in their tubes. We provide them and we will draw the blood. And then we give you the gift card and we take the blood with us to then ship it. We do have a tight window to ship them out to the respective labs, so we take care of that.
Okay, that's really nice that you guys come collect it. Somebody asked, have you guys considered adding smaller health systems within research departments to the study?
Absolutely. And in fact, we are working with some different health systems like Community Memorial Health System and others. And we do have in the Tappahannock region and where you all are, we do have primary care clinicians that we've worked with, and some of the health system and practices are there. But if you were thinking of any system or group in particular, Kathy, if you let us know, we can reach out to them as well.
And I see you guys are including rural community members. How else do you guys collect feedback from rural communities? Do you guys go to different hospitals and advertise and get their opinions, or how do you hear from the rural community?
Well, this is one of the pathways we wanted to do. And Kathy, Riverside is a group that we work with. We actually have one of our family medicine residency programs is at Riverside, and we've worked with Riverside practices since 2004 doing studies collectively. So they're a great group, and they're part of our ACORN network, and we collaborate. So they are engaged and involved in this in some ways. I think we've been working with the primary care clinicians in some of the communities to understand their perspectives, and around Community Memorial Hospital, we've been working with some of the care team members there and talking with some patients there to get input as well. Gabby, you've talked to others. If you have others, did I miss any?
No, yeah, we make our, we do a lot of outreach. We try to, make connections through connections to figure out, how we can get feedback. And even as I meet with participants, I get their input about the process, to just kind of learn from that and be able to adapt. But I think we've presented to one of the cabs previously while we were still in the planning phase last year. And but we want feedback ongoing. So yeah, this is great. And I will add too that out of the 10 hubs, Virginia was the first one to start. So we have essentially been sharing what we've learned and what the feedback we've received with the other hubs across the country. So this is really good. We also did, what did you call them? Engagement sessions?
Studios. Yes.
Studios.
Studios.
Yes, we did those last year where we, got feedback from different cab members, from different groups. And so I think we're going to plan to do that again.
Well, thank you. And if the Vanguard study shows that the multi-cancer detection tests are effective, what are the next steps before they become available to the public, or are they already available?
You want to answer it, Gabby?
I was just going to say that some of the tests, including the 2 that we're using, are commercially available. So you can go directly to the companies, pay about $1,000, send your blood sample to them, and they will get back to you with similar results, the same results that we're giving you. But yeah.
Okay, so this study is very unique because instead of paying to get the service, you're getting paid to get the service.
In a sense, yeah.
Potentially, you could also be in the control group. But so we are, from the research study standpoint, interested in people who would be willing to be in the control group as well. So, but yes, you could get this test that you would normally have to pay for. And just from a policy standpoint, what's really interesting is that in order for this to be covered, we need evidence to show that this saves lives. And if we get evidence that shows that doing this test prevents people from dying from colon cancer, then there's a group called the U.S. Preventive Services Task Force. They make those different national guidelines on what cancer screening tests we should and shouldn't get. And they need evidence showing that this test saves lives. If they're able to get that evidence and we show that the test saves lives, then they would recommend that people routinely get this test. And if they recommend that people routinely get this test, then that it's covered under the Affordable Care Act with no cost to people at all. So it would go from costing $1,000 a test to being free if we can show it saves lives. So that's a big reason we want to do the test, do this research study.
Awesome. Ms. Kim asked, should people consider themselves screened if they get either of the blood tests within the study?
Absolutely not. And that's a big important point. And I'm really glad you asked that, Kim, because the patients who get the blood tests, meaning they did get screened with this new test, but if they don't do the other things, then they have not had their cancer screening. So we would want, women, if they're of appropriate age, to continue with their pap smears and their mammograms and colon cancer screening and lung cancer screening, and men to continue with the lung cancer screening if appropriate, colon cancer screening, and talk about prostate cancer screening. So if you do all of those things and get the blood test, then yes, you are screened, and yes.
Thank you for answering. Are there any other questions anybody would like to ask? And you are allowed to unmute if you want.
Or feedback or suggestions.
I will add our emails and the interest form on our website, should anybody want to just reach out, either to participate or to learn more, or if you have questions, you can reach out to us and we would be happy to get back to you.
Or you can send us places, organizations, or events that we should work with to try and promote this.
You all see that someone put in the chat, Riverside would be interested in joining as a health system.
Yeah, and Gabby was asking if there's a specific clinic. We've worked a lot with Riverside, and so yes. So Kathy, if you tell us if there's a specific clinic or practice, or otherwise we can generally contact them.
Kathy, thank you.
What is Rural Health Connect? This website is for health education, resource sharing, promoting community events, health webinars, and celebrating neighbors. The website is definitely not for medical advice, for accessing telehealth appointments, for emergency medical services. It's also not a consumer marketplace or a platform for paid advertisements. On Rural Health Connect, you'll notice there's several tabs at the top of the page. The first is a home tab. It has a news feed. It features articles and blogs and other posts from around the site. There's an events tab. It has local and virtual events. There's a discussion tab. The discussion tab features forums for discussions about rural healthcare. There's a news tab. The news tab has articles, recipes, resources, education about health topics, as well as community partnerships and knowledge checks. There's a resources tab. It features maps for food assistance and community care. There's a research opportunities tab. There's clinical trials available there that may be relevant to rural citizens. When you visit ruralhealthconnect.org, you'll notice that the events are organized in both a list and a calendar format. Either one is fine to use. A few of the kind of events that we feature on the platform are Remote Area Medical, which offers free dental and medical care to rural community members. We've also had virtual events like Let's Digest, Gut Health and Colorectal Cancer Prevention with Mindy Conklin of Hitting Cancer Below the Belt. RuralHealthConnect.org features a broad range of information about health topics, from children's health, disease prevention, food assistance, senior care, self-sufficiency, home gardening advice, healthy recipes, and resource maps. In summation, ruralhealthconnect.org is apolitical, community-guided, there are no advertisements, and there is a dedicated research team to help you with any questions you may have. There's articles, discussion boards. If you're interested in learning more, please get in touch. Call us at 757-537-0651 or email us at vhsctsaelemente@odu.edu. Thank you for your time. To sum everything up, Rural Health Connect is apolitical, community guided, there are no advertisements, and there's a dedicated research team to support you or any questions you have during your journey on ruralhealthconnect.org. We provide lots of helpful articles. There's also discussion boards so you can state your concerns about your healthcare in rural communities. If you're interested in learning more, get in touch. You can call us at 757-537-0651 or email us at vhsctsaelemente@odu.edu. Visit ruralhealthconnect.org/page/about to learn more about our program. Thank you.